Hello and welcome to today's MassHealth Care Planning Learning Collaborative webinar on integrated care planning for Medicaid members with complex needs, lessons from MassHealth. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be moderated question and answer sessions during today's event. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Carla Silverman, Associate Director of Complex Care Delivery at the Center for Healthcare Strategies.
Thanks so much, Travis. Welcome, everybody. I'm Carla Silverman, Associate Director for Complex Care Delivery at Center for Healthcare Strategies. We're delighted to have Gary Singh from MassHealth with us here today, as well as representatives from the ACOs, primary care practices, and community partners in Massachusetts, including Leah Jackson, Jennifer Shaka, and Dr. Christine Rooney. Next slide, please. The Center for Healthcare Strategies is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. Since 1995, CHCS has worked in every state in the nation. We partner with state and federal agencies, health plans, providers, community-based organizations, and consumers to make healthcare work better for people who face serious barriers to well-being. Barriers like poverty, complex health and social needs, and systemic racism. We work to advance more effective models for care delivery, more efficient policy and program design, and across all our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for people facing the greatest disparities. Next slide, please. On today's webinar, you will learn about MassHealth's innovative work supporting partnerships between accountable care organizations, otherwise known as ACOs, and community partners that are referred to as CPs. We'll explore key takeaways from the MassHealth Care Planning Learning Collaborative that can inform activities in other states. And we'll discover how interorganizational collaboration and improved processes on the ground can positively impact the delivery and quality of care for people with complex health and social needs. Next slide, please. So for today's agenda, we'll do a brief overview of the MassHealth ACO program and MassHealth CP program. We'll share some key takeaways from the Learning Collaborative. We'll have an interview with MassHealth, and then we'll have a panel discussion with representatives from the ACOs, CPs, and PCP practices in Massachusetts. And then we'll have time for some Q&A. Next slide, please. Today, we're excited to share with you the lessons learned from the MassHealth Care Planning Learning Collaborative. This learning collaborative was supported through Massachusetts DSRIP program, which is authorized under MassHealth's current 1115 waiver. The DSRIP program supports the development of accountable care organizations, networks of primary care providers that work in partnership with hospitals, community partners, and specialists to coordinate a Medicaid member's medical care, behavioral health care, and long-term care needs. Center for Healthcare Strategies led the MassHealth Care Planning Learning Collaborative with their partners at the Camden Coalition of Healthcare Providers and with support from MassHealth. Our goal was to provide technical assistance and coaching for the ACOs, primary care practices, and community partners in their efforts to engage in shared care planning for members with complex health and social needs. Shared care planning was seen as central to MassHealth's efforts to provide comprehensive, coordinated care by an integrated interdisciplinary team, but often required collaboration across separate organizations who may or may not have worked together before. This was additionally challenging because many of the organizations deliver similar but slightly different services and in service of different goals. And ACOs, PCP practices, and behavioral health and LTSS CPs had and have different cultures. Improving shared care planning would mean finding a way to bridge gaps and cultures between ACO providers and staff at PCP practices and behavioral health and long-term service and support community partners who themselves were working with multiple ACOs and primary care practices across the state. The Learning Collaborative began in March 2020, and as you might imagine, we had to shift and adapt our plans because of the pandemic. We worked closely with MassHealth to move our Learning Collaborative into a fully virtual format. And right here, I'd like to call out the tremendous work that the Learning Collaborative participants, clinical and administrative staff from the ACOs, PCP practices, and CPs put in to make this Learning Collaborative successful, despite the pandemic, and despite the fact that they and their colleagues were caring for patients with COVID, staff themselves were suffering, many practices had closed down or slowed down at various points, and there was tremendous stress and trauma that people were experiencing. 22 ACOs and CPs voluntarily partnered together to work on improving their specific shared care planning processes around members that they both provided care and support for. Each team received technical assistance and coaching from CHCS and the Camden Coalition on identifying problems in their shared care planning process, testing solutions for those problems, and then rolling out and scaling and spreading those solutions beyond their teams. The Learning Collaborative also featured multiple subject matter experts who lent their expertise and who led webinars on topics such as best practices in integrated case conferencing, strategies that support high quality collaboration between PCPs and community providers, and best practices in engaging hard to reach members in care. The Learning Collaborative emphasized peer-to-peer learning and sharing. Next slide, please. Before the Learning Collaborative began, CHCS conducted a series of key informant interviews with a diverse array of stakeholders to better understand the challenges that ACOs and CPs faced as they tried to plan and deliver care as integrated teams. As an example, many ACOs provide a team of care managers, often nurse-led, who help with assessments and the provision of resources and care coordination for members flagged as high risk by the ACO. In turn, some PCP practices also provide care management or care coordination, although not all do. And CPs, the community providers who often have the strongest relationships with members with complex needs, also provide care coordination and navigation for the people they provide services and support for. Teams of nurses, social workers, care coordinators, care managers, community health workers, and primary care providers needed to work together effectively and efficiently to provide high quality care. Core themes noted by CHCS at the beginning of the Learning Collaborative, around which we built the focus of the work, the focus of the Learning Collaborative included knowledge gaps about how ACOs and CPs were expected to collaborate across organizations, and a lack of knowledge about the role their organization and other organizations played and what everyone's processes were. We also heard about lack of role clarity between the different team members and frequent duplication of processes, like multiple organizations reaching out to a member. There was also a feeling that the member might not be at the center of the care planning if a team-based approach wasn't adopted and working well. There were communication barriers, including trouble knowing who to contact and how, things like front desk staff and other organizational members who may or may not have been aware of the collaborative teams that their organizations were part of, or why an ACO or a PCP practice or a CP was calling them. We heard about an enrollment process for members who needed assistance, sometimes quickly because they were in crisis, but that could be easily delayed or derailed. And finally, there were challenges sharing data about members, including the lack of shared technology and multiple EHRs and care management systems. Next slide, please. So our objectives for the Learning Collaborative were to streamline processes between ACOs and community partner teams and create clear communication pathways. We wanted to build and formalize relationships between key contacts at the ACO, primary care practices, and CPs, identify organizational leadership needed for successful care planning between ACOs and CPs, identify promising practices for shared care planning and ways to measure progress in that shared care planning, and finally to scale and spread successful process improvements to partnering organizations. Next slide, please. Here on this slide are some key solutions that were developed during the collaborative. And I want to note here that it's easy to think of care planning as simply a plan, a document, a piece of paper, so to speak, that needs to be filled out that shows what the plan of care is for a member and what their priorities are. However, our approach and what we saw play out is that for shared and integrated care planning to work, all parties must think about and work on the care planning process and not just focus on the document. Once everyone understands and commits to the idea that process needs time and investment and needs to be developed and practiced, then many things fall into place in terms of its improvement. That being said, we saw that focusing on relationships across all teams led to very positive results. Investment in terms of regular meetings, which in this case became Zoom meetings or phone calls, were helpful and led to better coordination into teams that could rapidly respond to members' needs. Also, having clear communication pathways for the whole team was critical to being able to deliver high quality care and support to members. Through the Learning Collaborative, teams worked out who to call for what types of issues and clarified expectations around how quickly team members were expected to respond to one another. Many teams instituted integrated case conferences conducted over Zoom or by phone, which gave teams a standing meeting to which they could bring challenging cases or review current shared members to get on the same page about current and future needs. Finally, many teams explored innovative ways to use technology to support collaboration, whether that was responding to ADT feeds or using texting platforms to communicate with one another or with members. We'll be getting more into the weeds on all of these key solutions and more when we talk with our panelists later today. But now I'd like to move to our interview with Gary Singh from MassHealth. Welcome, Gary. One moment as I pull up. So sorry. Hang with me here for one moment. Okay, Dr. Singh, I'd like to introduce you, and we're so happy to have you here. Dr. Singh is the Director of Delivery System Investment and Social Services Integration at MassHealth, Massachusetts Medicaid Agency. He is a member of the innovation team at MassHealth and oversees various investment programs, including MassHealth's Delivery System Reform Incentive Payment Program. Gary also works to advance integration of health-related social services into MassHealth, which includes overseeing the design and implementation of the Flexible Services Program. This pilot program allows MassHealth ACOs to use state and federal Medicaid dollars to pay for certain health-related nutrition and housing supports for certain eligible members. Prior to joining MassHealth, Gary worked as a strategy consultant in the life sciences industry, earned a PhD from Harvard University in engineering sciences, and earned dual BSEs from Duke University in biomedical engineering and electrical engineering. Welcome, Gary. We're so happy to have you here. I'd like to begin first to ask you about MassHealth's managed care strategy. It's been significantly restructured, and would love to know what this restructuring looks like and what it's trying to accomplish.
Well, first, thank you, Carla, and to the CHCS and the Camden Coalition team for all of the great work that you have done in helping to support this, the learning collaborative that we're talking about right now. So as some quick context, MassHealth, we cover around 2 million members here in Massachusetts, which is a little more than a quarter of the Commonwealth's population. We have around 7 million residents here in the state. So we first implemented managed care in the early 1990s through an 1115 waiver. And since then, we've continually sought to extend that waiver. And one key expiration date that was coming up was June 30th, 2017. So at that time, our waiver was approved until then. And CMS basically told us that unless we do some significant restructuring of the program, we won't renew your 1115 waiver, and that brought to risk more than $1 billion per year in funding for our safety net providers. And so, as you can imagine, this provided a really urgent window of opportunity for us to restructure our program and to negotiate a new waiver with CMS. So what was driving all of this? Well, from 2010 to 2016, we experienced unsustainable growth that was really being fueled by a fee-for-service model for providers that resulted in fragmented care and a fundamental program structure that hadn't changed since that initial introduction of managed care in the early 90s. So with this in mind, we decided to implement an ACO program to strengthen value in care delivery, to better meet our members' needs through more integrated and coordinated care, and to moderate the cost trends while maintaining or improving clinical quality of care. In addition to the ACO program, as you mentioned earlier, we decided to implement a companion program called the Community Partners Program, capital C, capital P. And here, these are entities that are community-based organizations that provide specialized care coordination supports for members with certain behavioral health and long-term care needs. And to help support the new ACO program and the new companion Community Partners Program, and to also provide a substantial carrot to promote participation in our restructuring efforts, we worked with CMS to implement a $1.8 billion Delivery System Reform Incentive Payment Program, or DSRIP for short. And so we really view these three programs, the ACO program, the Community Partners Program, and the DSRIP program as our three-pronged strategy for our managed care restructuring efforts.
Great, thank you. Can you talk about how MassHealth chose to use DSRIP funds to support ACOs and community partners in improving their collaborative relationships?
Absolutely, yeah. So I briefly want to just mention that unlike other ACO programs, our ACOs are networks of primary care providers that work in partnership with hospitals and specialists to coordinate all of a member's physical health, behavioral health, and long-term care needs. And so in implementing the ACO program, as I mentioned, we wanted to really move away from the fee-for-service payment model into a value-based model that would incentivize this integrated care and this collaboration between the ACOs and the CPs that you're referring to. So we've been able to leverage DSRIP funding in 4 general areas. So the first one is startup funding for the ACOs. Many of these entities did not exist prior to our restructuring, and there was necessarily some startup funding that would be needed for that. 2, the second bucket was startup funding for these community partners, as well as payment for the actual care coordination supports that they were providing. 3, we wanted to set aside some funding to support ACOs and CPs by making investments in statewide infrastructure, workforce capacity, and technical assistance. And really the thinking here is that, yes, you can provide funding directly to ACOs and CPs, but if the ecosystem writ large is not adequate to support them in those efforts, then there's going to be some missed opportunity there. And in fact, the Care Planning Learning Collaborative that we're talking about right now is funded or was funded through that third bucket. And then a fourth bucket was for state operations and implementation. Given that the integration of historically siloed health sectors was one of the key goals of the DSRIP program, we tried to promote integration between the ACOs and CPs as much as we could. So for example, we only made DSRIP funding available to ACOs if they partnered with CPs and vice versa. And really the rationale behind this decision was that having ACOs, their PCPs, and the community partners work together in this integrated team-based care model would result in improved health outcomes and reduced total cost of care. And the logic there is many of our members who utilize the most amount of services often suffer from multiple chronic physical and behavioral health conditions, as well as health-related social needs. And so having the support of this integrated team to help with the care coordination and the juggling of all of the balls can really make a meaningful difference, both for the individual members and also at the larger population level.
Yeah, and we absolutely saw that in the Learning Collaborative. I'm wondering if you can provide us context around the decision to invest state dollars into improving shared care planning. Specifically, I know we thought that was super exciting and sophisticated that you guys landed on focusing there. And did you feel that improvements in shared care planning between the ACOs and the CPs would lead to improvements in outcomes for members?
Yeah, there were a number of reasons why we decided to support this Learning Collaborative. So first, the document itself, the care plan, we thought would be an important place to invest because this is, in essence, the plan or the strategy that the member will be engaging with to improve their health and their quality of life. And given that members' needs often span multiple domains, care planning can really benefit from an approach that integrates team members from the ACO, from the PCP office, from the CP, from all these different silos. And we felt like it'd be important to really invest in this important step. Second, when the program first launched, as you just mentioned earlier in your remarks, there were a lot of challenges with this joint care planning process. Part of it was, this is a new process for everyone. But I think one thing that might be helpful to provide context for folks about is what does the care planning process actually look like? And in particular, there's a key phrase that we use called member engagement, which had a defined meaning in our context. So member engagement in the ACO-CP MassHealth context is that the CP first has to find the member that has been assigned to them. The member has to agree to participate in the Community Partners program. The CP has to comprehensively assess that member for their needs, whether it's by themselves or in collaboration with the ACO. The CP then has to develop a care plan based on the needs and the goals that the member identifies in that comprehensive assessment. And then finally, both the member and the PCP or their designee have to sign off on the care plan. So this is a multi-step process where any hiccup along that way would lead to that care plan not being signed by the PCP and the member. And one of the other considerations here is when we designed the CP program, we designed it in such a way that payment for the CPs was actually linked to member engagement, AKA signing the care plan by the PCP and the member. So if the care plan wasn't signed, that would actually have a potential financial impact on the CPs themselves. So there's all of that context that I just provided around why the engagement process can be challenging. But I think a third reason why we felt like we wanted to invest in the care planning work is we designed the quality measure slate for the ACO program and the CP program such that both of them had shared measures and shared accountability for member engagement. So again, this would also have a financial impact on both the ACOs and the CPs. We wanted to align that incentive so that everyone is moving in the same direction. Now, as you mentioned earlier, care planning, the care plan itself is a document, and that the collaborative process behind the development of that document is just as important. And so we recognize that, and which is why we wanted to invest in this learning collaborative.
That's great, thank you. And makes a lot of sense. I'm wondering if you can talk briefly about some future goals that MassHealth is focusing on to strengthen integrated care in Massachusetts.
Yeah, so integrated care is a core focus of our current 1115 waiver, and will continue to be a priority during our next waiver period, which actually will begin in less than a year on July 1st, 2022. We're currently preparing our waiver renewal proposal to CMS, and we intend to maintain the Community Partners program with some adjustments to reflect lessons learned. There are a number of other parts or components of the waiver proposal that are supportive and aligned with integrated team-based care, such as implementing primary care subcapitation payments for our ACOs to pass through directly to their primary care practice sites, so that those practice sites can get off the fee-for-service treadmill and have the upfront financing to hire expanded care teams and staff, such as community health workers or other frontline staff. Additionally, we'll be continuing another innovative component of our current waiver, which is the Flexible Services Program, which I think you gave a brief description about during my bio. But essentially, this program provides funding to ACOs to pay for certain housing supports and nutrition supports for eligible members, really in the hope that in that closer integration of these health-related social services with medical care can lead to improved health outcomes, member experience, and reduced total cost of care. And finally, one major area of focus for our next waiver is our investment in health equity. Here at MassHealth, we recognize the importance of identifying and actually reducing health and healthcare disparities. And so we'll be offering substantial financial incentives to our ACOs and ACO participating hospitals to do just that work. Much of the work that ACOs and hospitals will need to do to close those disparities will necessarily require integrated care to help identify why do the disparities exist and what specific targeted things can be done to help close those disparities. So for folks who are interested about what we're currently planning for our next waiver and integrated care, you can Google the phrase MassHealth Innovations, and the first link will take you to some web pages where you can find out more information. Thanks.
Thank you so much, Gary. So helpful. I don't think we have questions, but I just want to take a minute and invite anyone who wants to ask a question from the audience to put your question in the Q&A. We have a team ready for your questions, and also we're happy to take them right now. If not, if your questions come up later, we're going to be doing more Q&A after the panel discussion. So I think maybe, oh, wait, it looks like we do. Yes, so we have a question, which I could answer, but I'll give it to you, Gary, and that is, are FQHCs in your ACOs?
Yes, we have many FQHCs that are in our ACOs. In fact, the vast majority, if not all of the FQHCs are participating in our ACO program.
Yeah. We have another question. What specific measures were or are being taken to ensure that persons with IDD have access to mental and behavioral health services?
Yeah, I'm thinking through. I'm thinking to our measure slate, but I think more directly, any medically necessary services that a member requires, the ACO is contractually obligated to ensure that they are receiving those services. I'm trying to think about if we have any specific quality measures focused specifically on the IDD population. I don't believe we do, but we certainly do have a number of behavioral health measures. So if you wanted to see what those specific measures are, the measures are contained in what's called our district protocol, which is a CMS document that we have aligned on with CMS. If you look at Appendix D in this district protocol, you'll find the measure slate there.
Thank you. We're getting a bunch of questions. I'm going to take one or two, and then we may save some of the rest of them for later. But we have a couple questions here related to measurement. And I like this one in particular. Someone is asking, what are some shared measures that you feel catalyze cooperation among organizations? I don't know, Gary, if you have thoughts about that.
Yeah, well, one of the key measures that I alluded to earlier was in the ACO quality measure slate and the CP quality measure slate, we have a measure around member engagement, which, as we discussed, is really considered a member's engaged when that care plan is signed. So that is probably one of the primary measures that we're using to assess whether progress is being made on that collaboration. Now, obviously, that is a process measure, and really the rubber hits the road when you start looking at some of the outcomes measures. But from the pure tracking and incentive approach, it's that shared that member engagement measure.
Yeah, I would agree with that. Measures that emphasize people working together, that you have to meet by actually collaborating. Okay, I'm going to move us along because I want to make sure we have time for panelists, but we have many questions coming in. Please continue to put your questions in. Our team will either answer them or we will send them to Gary and his team and circle back to them after the final panel discussion. Thank you so much, Gary. It was great to speak with you. Okay, so now I would like to welcome our panelists for this next part of the discussion. First of all, we have Leah Jackson-Keene, who is a licensed social worker, and she currently works as director in Elliott's Behavioral Health Community Partner Program, overseeing the Care Transitions team. Leah has been with Elliott Community Human Services for 11 years. She previously worked for one of Elliott's CHCS DMH contracted programs in the Metro North area. She graduated from Lesley University with a with a Bachelor of Science degree in counseling and completed a Master of Social Work degree from Smith College School for Social Work. She's always interested in transitions of care, and she published her master's thesis titled Clinician Perceived Barriers to Effective Discharge Planning for Youth Coming Out of Residential and Inpatient Treatment. Welcome, Leah. You can turn your camera on if you'd like. Yes, hi. I'd also like to introduce Jen Shaka, who is the Long-Term Services and Supports Program Manager for the ACO MCO Community Partners Program at Boston Medical Center Health Net Plan. She partners with LTSS community partner organizations on behalf of the plan's ACO and MCO products on strategy, operations, and program sustainability. She's worked at BMCHP for over 6 years in different roles, including oversight of the plan's clinical vendors, and is dedicated to the improvement of sustaining quality relationships with external organizations and providers to improve the experience for the plan's members. Her background is in macro social work and program management and improvement. Welcome, Jen. And finally, I'd like to introduce Dr. Christine Rooney. Dr. Rooney is a family medicine physician with over 20 years of experience caring for patients of all ages in Massachusetts. Her sense of adventure and desire to try new things have certainly been fulfilled since 2001 through her work at the Greater Lawrence Family Health Center, and more recently with the Merrimack Valley ACO. As the Greater Lawrence Family Health Center AVP of Clinical Initiatives, she's led system-wide projects related to behavioral health integration and expert screening with EMR facilitation, among other interdepartmental initiatives. In her role as Merrimack Valley ACO Chief Medical Officer, Dr. Rooney brings her prior experience to the broader scope of accountable care to improve health outside of the clinic setting. She believes it is critical to ask not just what, but how healthcare is delivered to ensure that the best care is provided at the correct time. She holds appointments as faculty at the Lawrence Family Medicine Residency Program, Assistant Professor of Medicine at the University of Massachusetts Medical School, and lecturer at Tufts Medical School. Welcome, Dr. Rooney. Okay, so happy to have you all here today and very excited to get into this discussion. What I'd like to do is have each of you, and I'll start with Jen, say a little bit about the role that you play and the type of organization that you're at in terms of how it fits into the ACO CP program work.
Perfect. Thank you, Carla, and thank you for the opportunity to be here today. Very happy to be speaking with all of you. So like Carla mentioned, I work for Boston Medical Center Health Net Plan, and we are a Medicaid managed care organization that partners with provider systems across Massachusetts to form 4 accountable care organizations, or ACOs. We have a team of telephonic and practice-based care managers, mostly nurses who do patient assessments, provide care management, and coordinate care with providers and external agencies for members who have complex needs, including coordinating and co-managing members with the 9 LTSS community partners that we work with across the state. I oversee the LTSS side of operations, and happy to be here.
Great, thanks, Jen. Leah, can you introduce yourself and your organization and how you fit into this ACO CP program?
Sure, thank you, Carla. As Carla mentioned, I work for Elliott Community Human Services in the Behavioral Health Community Partner Program, and we're one of 27 CPs in the state of Massachusetts. As an agency, Elliott provides community-based services to adults, children, and families. BHCP specifically provides care coordination with an eye towards improvement of health outcomes by better integration of behavioral and physical health services for individuals with complex care needs. In my role as the Director of Care Transitions, I oversee care coordinators and nurses who collaborate directly with hospitals and other care sites to develop intentional disposition plans that incorporate the prioritized needs of the members that we're working with.
Great, thank you. And Christine, can you speak about your role and how your organization fits into the ACO CP program?
Carla, thanks so much. And thank you so much for having me be here today. This is really exciting to talk about the work we've done. So in my care family, we are comprised of primary care, clinical organizations, the largest of whom is Greater Lawrence Family Health Center, but we also have a number of smaller community practices. And as Gary mentioned, our program is designed around where the patient lives and where their journey exists. So our practices are located in the northern part of Massachusetts in the Merrimack Valley, primarily in Lawrence, Lowell, and Methuen area. We partner with 6 different behavioral health community partner programs, as well as 2 long-term service and support organizations. And my role really is helping to oversee these programs, as well as many other programs within our system, including the flexible services and others. So thank you for having me.
Great, we're so happy to have all of you. So I'd like to open this up and start with hearing from each of you why your organization, excuse me, wanted to be part of the Learning Collaborative. Hoping you can share a little bit of the work that your team or teams did during the Learning Collaborative and what some of the results were. So Jen, I'll start with you.
Absolutely, thank you. So we participated in 3 different change teams as part of the Learning Collaborative. And while we had strong written processes in place, participating in the Learning Collaborative gave us a chance to review those processes and really dig deep into the meat of what shared care planning is, identifying different opportunities where we could strengthen communication and collaboration across our teams. So that kind of resulted in enhancements on how we work together. And some of those we put in place, forming regularly scheduled rounding meetings to discuss shared members. And this is actually something that we are scaling to incorporate with all of our partnerships with all of the 9 community partners, because it's really important to have a venue where our care managers and the LTSS community partner care coordinators can come together and talk about their experiences and their work with our members. Another thing that we implemented was embedding a care coordinator from our community partner at one of our PCP practices. So this was very exciting because it puts that care coordinator right at the PCP practice with the flow within that practice. They're there 5 days a week. They also partner, so every member that's kind of referred into the program from the PCPs there that know their patients as well gets assigned to one of 2 of our care managers here at BMCHP as well, so they're co-managing together. So it kind of streamlines the process where this care coordinator knows exactly who they are going to be speaking to and who's part of the team. In that same vein, we've also consolidated the number of care managers that we assign to each community partner. So this kind of reduces that many-to-many relationship that's really important, so that our teams can get to know each other more easily and you're not working with so many different players. And then the final thing that we implemented was making sure that our teams were talking together sooner. So as Gary kind of outlined in terms of what goes into the engagement of one of our members, it's part of our process that we have to have an interdisciplinary care team meeting between the care manager and the community partner care coordinator after the member gets engaged. However, we found that a lot can happen between the time that a member is referred into the program, that they have an assessment by both the care manager and the care coordinator, that they start to work on developing the care plan, and then that care plan is signed. So we really wanted to get our teams kind of working together sooner. And all of these things that we put in place were really to kind of enhance the relationships between our teams and to get us talking right off the bat about the members that we jointly manage.
Great, thanks, Jen. Leah, can you talk about why Elliot joined the Learning Collaborative and some of the work you did and results?
Absolutely. I mean, I think similar to a lot of the points that Jen made, we had a desire to hear about the experiences and also the problem solving of the CPs and the ACOs at the program level. So we could really have an opportunity to explore different types of improvement measures. So we focused a lot on internal and external workflow development to work towards shared goals. So member care goals, financial goals, performance-based goals. One of the things that we did that, I think worked really well was connect with our practice sites around care transitions. And so knowing that the ACOs and the practice sites are again doing some similar work around member transitions of care, we partnered with them to do that together. So it helps with some of the member fatigue that of course Jen was talking about. And we're really working toward the shared goal of the CP, of the ACO, and of the member, and we're able to do it in this collaborative and cohesive way.
That's great, thank you. And Christine, can you talk about why your organization joined and some of the work that you all did?
Of course, I think some of the other comments that Jen and Leah made are really important here. And taking a step back, I think this ACO program really looks at the journey of the patient. Traditionally, healthcare has thought about health as being administered and managed solely in a medical setting, but most people don't spend their entire life in the doctor's office. So really pulling the community people, the organizations into this and helping to bridge those silos that existed has been really pivotal. The care coordination that happens really needs to be part of a communication process. And this improvement happens at both levels. One is the individual. How do we work with a person to help them improve? What are their goals? Next is how do we build these processes, these systems around it such that we do the easiest thing and the best thing for people, the right time, the first time, and the patients navigate their way to the best source of care initially. So in our work together, we started looking at it from these angles and understanding that so many people have really good intentions in doing work, but gathering together in conferencing, weaving our community partners into our programs, realizing that we have shared patients. So our long-term service and support patients and our ACO care managers were working simultaneously on the same person. So let's talk about that. Let's build our forces together. And those were some of the really good things and other communication strategies of how do we work with patients in a real-time fashion with alert systems and other texting campaigns. So quite a bit of collaboration, and it's been quite useful to have that knowledge and the expertise of our community partners in our program.
That's great, thank you. I want to follow up with a question that maybe you've already answered, I'm not sure. So I'm just going to invite anyone to add something if they have something to add here. But we know that you all worked on improving shared care planning across ACOs, PCP practices, and CPs. But I wonder if you can speak to what is challenging in particular about this kind of inter-organizational collaboration and what you felt like high quality collaboration across organizations that were not related, that had separate leadership. Like, what did that look like? Anyone who wants to weigh in here can do so.
I'm happy to weigh in. You know, when I think about what our quality collaboration has really looked like, it's looked a lot like working together on these member-centered goals, while also being attentive to the needs and the strengths and the limitations even of the care partners who are involved. So flexibility and responsiveness have been really important qualities across the board for CPs, ACOs, and certainly the members as well. You know, understandably, ACOs are often working at a higher level than the practice sites, which can sometimes make goal alignment a bit more difficult, but CPs are really looking to collaborate with both the ACO and the practice sites, which are sometimes functioning independently of the larger ACO and CP goals, just based on the needs of the communities that they're serving. And so as a CP, we're really always wanting to be asking ourselves, how can we participate, or how can we be active participants in facilitating change in these types of care dynamics? So we're helping the members as much as possible.
Thanks, Leah. Jen, you looked like you wanted to pipe in.
Yeah, I'll just add, and 100% Leah, I definitely agree with everything that you said. And also, I think one of the challenges that we faced was that while we had these strong processes in place and this idea of integration, the challenging piece was really getting each individual involved in the shared care planning to have that mindset that they're working in a team and not just as an individual contributor. So really getting that into the process right when a member is referred into the program, having our care managers know that they need to identify, is this person assigned to a community partner, which one, how do I outreach to them, getting that kind of front and center of the care planning, that they're part of this bigger team is just really challenging. It sounds easy, but it needs to be part of all of our flows.
Yeah, go ahead, Christine.
Thanks. And I'll add to that. I think when in our organizations, we have, 8 different community partners, hospitals, primary care practices, thousands of patients. Realizing we're building something new, something unfamiliar to the people in this community, the idea was to build one person, a liaison, a central point of contact for our organizations that helps tie together all of these different organizations that they all know they can contact her. We built the role of a community partner relationship manager, who's a social worker who has prior experience in behavioral health referral strategies, so really understands a lot of these needs and how to work with different organizations. And she's able to talk to our community partner, as well as our primary care practices, facilitate the coordination of the shared care planning, as well as, help run our case conferences, and really has been, some of our community partners have said that's been like a gold standard for them to be able to have that, especially as we started and everyone was trying to figure out where we all existed. And now I think the systems are really quite nicely up and running across all the ACOs, but it's been really helpful to have that person doing the role.
Yeah, we saw that as well. Thank you. And I guess I just want to highlight one more time, this is really new, right? Like the idea, as you said, Jen, that we're a team, but we come from separate organizations, but we have to think of ourselves as a team and coordinate with each other to better meet the needs of the people we're caring for. It's pretty radical and revolutionary to not all be under one house and one leadership and to make it work. So congrats to all of you that you have made this work. I want to move to talking a little bit about data and information sharing, which, for everyone across the country is challenging, and much more so when you're working across organizations who are not in shared systems. Can any of you, whoever would like to speak up, share any innovations you came up with or tools to improve the sharing of care plans or other data across organizations?
I'll jump in.
Great.
I think communication is so important, and communicating the right information in the right way is even more important. We've all had plenty of Zoom over the past year and a half. And, there's always another meeting you can have and always some other thing, another email to read. So in the shared care planning, we looked at these really rich documents that tell an amazing story about a person, where they live, who their supports are, what their goals are. But realizing primary care doesn't have really dedicated time to sit and digest that, we developed a cover sheet. And within the cover sheet, we listed who the care manager was, how to contact them, when the last primary care appointment was, as well as have like a box of space that would list what tasks the primary care would be asked to do, what tasks the care manager would do, and any communication feedback. And I think this really helped people dissolve down like what was the information they needed to know and how to find more information later. And it was really helpful in communicating. DocuSign made the care plans much easier to transmit back and forth between entities. So that may be a silver lining of the pandemic. So those are a couple of our things. We also use some other alert notification systems like collective medical technology. I'm not sure how familiar this group is with that. It's a system we have in Massachusetts, and it may be national, in which emergency rooms, catalog when patients are, coming in for appointments or just visits there. And over time, we learned that we could look at those patients who are frequently seeking care in the emergency room and make a notation within that system when a person who is part of my care family who has multiple emergency room visits, when they come in, please call their behavioral health community partner care manager at this number, or to help coordinate their transition of care, their care discharge planning, connect them back with primary care. And that has been really helpful to keep patients better connected in their journeys. They go wherever they feel is appropriate. So how do we help them get back to a place that's safer, with better care and better quality care?
Great, thanks, Christine. Go ahead, Leah.
Thank you, Christine. I think I would agree. In addition to some of the larger platforms that have really allowed for information sharing from a CP perspective, we've also been able to begin receiving ACO generated reports. So with different data sets, cost information, risk, demographic information, sometimes even upcoming appointments, and that really allows us to inform our work with members, even if it's our initial outreach and engagement, because sometimes we're doing that from a transition of care or just calling people as a referral source, and they may not have had a touch point into the program otherwise. And so having certain information points can be really helpful in that initial outreach as well.
Yep, and I can just add to that also. So all of those pieces, I think if I had a magic wand, I would love it for all of these organizations to be in the same system, but because that's not the case, we kind of have to work around that. We get a lot of reports, kind of like Leah said, and it's not really efficient to have all of our care managers or care coordinators looking at 15 different reports. So what we like to do is aggregate that information into a digestible format. So I know we're getting our shared list of, or shared rosters of members on who is in the program, but I'm adding information like how many members have had a comp assessment and who those are, information that the CPs give us in terms of where they are in the process with a member, whether a member is engaged, their last contact that they had with a member, aggregating all of that information and disseminating it to teams so that we only need one report versus the many reports. And then having those spaces to have further conversations. So we're all sort of talking with our members, but to have a space where we are coming together to have a conversation about what's happened or what information we have in our system is also really pivotal. And then one other thing, we're also taking these reports and making sure that our care management system has keywords in there so that our care managers know exactly who the member is assigned to, know exactly which organization to work with is also really pivotal.
Great, thank you, so helpful. So I'd like to pivot and talk briefly because there are a bunch of topics I want to get to and our time is starting to close in, but anyone who'd like to comment about your integrated case conferencing process? Did you set those up? Did you do them before? How does that work? How has that been helpful? Anyone who'd like to weigh in here?
Sure. So our most successful integrated case conferences have really come about by identifying, again, shared goals by the ACO and the CP. They're including formal roster reviews. And the attendance at these is really, who will have the greatest impact, so to speak, on the member care needs that have been identified for those particular meetings. Again, from a care transitions perspective, we're certainly reviewing high cost, high need members who are frequent utilizers of the hospital system. We also have the opportunity to discuss difficult to engage members. So Gary talked about engagement as a core concept of the CP program. So whether they're minimally engaged with us as a CP or minimally engaged with the practice site or sometimes both. And we're also able to review any care plan challenges in these meetings. And this type of interface has really allowed CPs and ACO partners to collaboratively recognize the complexity of needs of the members who are being served in these programs and be able to develop appropriate and integrated interventions.
Yeah, I love what you said about the collaboratively, understand the complexity of needs. That's so important. And I think these case conferences have really helped us do that. We've tried to incorporate our community partners into any case conference we have. A couple I'll highlight are one of our patients who have multiple visits to the emergency room, understanding that that's more of a symptom of something else that's lacking than often a medical need. And if there's a lack of housing, food issues, behavioral health, unaddressed issues, those are things that we're working with. In these conferences where they'll have 15 different people with multiple roles, including our community partners, recovery coaches, community health workers, emergency room navigators, primary care, to really build on that idea that we all have a piece of knowledge that helps this person to be supported. Just an example of our case conference was during 2 of the COVID waves, a local hotel was turned into a temporary shelter. And so our shelters needed to be depopulated. And we built a program that incorporated our Always Health Partner Utilization Management Team, home health agencies, community partners. Our mobile health unit went to the shelter to see patients. I think in the second wave, about 250 people were served, about 100 of which were in our ACO, and 87 got their COVID vaccines with 122 visits. These are people that haven't had care. Yet the other programs like Elliott went there and they helped people with housing and they helped enroll them in community partner programs. I think the value of really pulling our skills into one place and following the patients where they are is key.
Thank you. So in our last moments here, I want to get in. I want to get in this last question, and we can circle back if we have more time. But I'd really love to hear from each of you what you thought was your key takeaway or learning, or what your organization thought was the key takeaway or learning from being involved in the Learning Collaborative and doing this work. Whoever wants to start, I invite you to start. Maybe Jen, we'll start with you since you didn't answer the last one.
Yeah, absolutely. I think the biggest thing that we got out of this is that need to build relationships. Christine, I like what you said about we all have a little piece in sort of a member's journey. That's completely important. And I think that relationship building not only builds trust with our members, because our member knows that a team is working with them and they don't have to retell their story over and over again, but also just the trust between our teams to know that a care coordinator may be working on this piece with connecting a member to resources in the community, or the care manager is going to be working on this piece. Building those relationships is really essential to the work that we do.
Yeah, I would agree. And I would add, connection to hospitals and facilities and the ability to leverage those relationships that have been developed over time to connect with members and really facilitate really quality coordination of care.
And I'll just chime in saying, I'm in primary care, but I cannot do the work that a community partner program, a care manager in the community can do. And I really value that. One of my patients, I've known him since he was 13, and when he was 19, he came down with bipolar with psychotic features. He then was hospitalized 9 times in 2 years. And then he became a My Care family patient. I was able to connect him to one of our community partners who then helped stabilize him in the community, got him into a program, helped make sure he took his medications. In the last 4 years, he's only been hospitalized once in a community crisis stabilization center. I think that really attests to the value of how we all have a role in taking care of patients and keeping them stable in the community. As a primary care, I can't do that. I can't get him to those programs, but the community partner team really did an amazing job of keeping him stable, and he's doing much better now, and I'm very grateful.
That's great, thank you. We actually have a minute or two for one more question. So I think this is a good segue into a question that I skipped over, but is a critical question. And that is, I wonder how each of you think about member-centeredness or person-centeredness, because that's a key component to, I think, high quality care planning and a collaborative process that really meets the needs of the people you're caring for. So can each of you just talk briefly about how you center the member, or any approaches that you use to make sure that this plan of care is meeting the needs that they want met?
I would say staying mindful of the size of the care teams, and this is something that Jen spoke to a little while ago. As a CP, we have the ability to identify and maintain member stories, which helps, again, to reduce member fatigue and having to constantly repeat to providers why they might be seeking out a particular type of service. Motivational interviewing, of course, is key to member buy-in and helping to make sure that needs are prioritized and structured on care plans. And these types of things help with rapport when members know that their needs are being accurately presented and accurately addressed across the larger system.
Yeah, and I'll just add, so I want to remind that the care plan is really something that is created with the member and approved by the member. So if the member does not want to work on something at the moment, whether it's more medical, whether it's their diagnosis, new diagnosis of COPD or diabetes, that is not going to be the focus of the care plan. So that's something that is really important that we honor that, because that's how we build trust with our members. And sometimes our community partners can address things that are front and center of their mind. So for instance, if a member is really concerned about how they're going to pay rent or how they're going to put food on the table, our community partners can help with that stuff and have those kind of wins at the beginning to build that trust, to kind of then go to that next step of, okay, now let's talk about your diagnosis of COPD and how you can manage that. So it really has to be something that the member kind of agrees to and moves forward with, and that's really important and essential to the work that we do.
And I think by keeping the member central, that, just what Jennifer said is the person has said what their goals are. And the communication of that to primary care helps reinforce and keep everybody aligned on how to help the patient reach their goals, their self-defined things that they're trying to, improve upon, whether it be getting a GED, getting stable housing, transportation, or something medical, something more directly like get my A1C down to 7, anything, whatever they want. But it really helps to make sure that, and I've learned a lot from reading these care plans too, about the people's lives that you just don't have the chance to talk about in a clinical visit.
Great, thank you. So I think we're a minute ahead of schedule, which is great. And I think we have some questions here. So I'd like to turn to them. And I think if you feel like you guys can't answer them, we can see if MassHealth would like to answer them, or we can defer them. But the first one I have here is, and Gary, maybe this is for you. In California, we do not have much of an ACO environment. How is another way to get the HMOs and other entities involved? Any thoughts on that?
Yeah, it is a good question, and we do recognize that not every state has a DSRIP program or or has developed the community partners companion program like we've done here. So I guess just a couple of thoughts. So one is I guess I think about this from like a financing perspective and then an actual work perspective. So from the financing perspective side, like obviously it takes resources to be able to do the work that we're talking about, right? Such as hiring care coordinators. I know a lot of health plans have care coordinators, but they may not be operating in the way that we've just described, where there is a lot of expectations to do this integrated sort of management and care coordination with all these different silos. Maybe the care coordination that the plan coordinators are focusing on is just medical, as an example. So I think it's if you are in an HMO or an MCO or whatever kind of health plan, really broaden your perspective as to what kind of providers are you coordinating care with. And this, a lot of this is education, because it could be that that you just don't know about the behavioral health world, or you don't know anything about the long-term care world. And that is going to be a time investment to understand and to learn about that. But there are many experts who are living and breathing this stuff, who have written material or have presented on webinars like this, where you can, or even in your particular state, where I'm sure they would be happy to share more about what their experiences are. So that is using the existing financing that you have. The other part is, like, if you are in a health plan and you wish that you could have these resources, make a pitch to, this may sound naive, but like make a pitch to your CFO and see, hey, can you guys actually allocate resources to do this kind of work? And part of it is the resources. It is a real requirement. From the work perspective, even if you don't necessarily have the resources, you could maybe start small. Maybe there is a single BH provider where you have a lot of shared patients or clients or members with. And even if with the existing resources that you have, try a pilot with them or something like that, and see if working together with that one provider, you can actually start to make improvements with the shared care planning for a particular individual. And start small and then work your way from there. This is not going to be a silver bullet, but it is one step along the process. And the more evidence that you can show to your colleagues and to the people who control checkbooks, I think the better, and the more likely that they will be able to provide the resourcing for this.
That's great. Thank you so much. And that piece that you shared about start small, maybe you have one relationship and you can work on it and then scale and spread it, is exactly how we talked about the work in the Learning Collaborative, and I think is a very effective way to go. Okay, we have some other interesting questions here. We have a question. This is more, I think, for the clinical folks. Any innovations to share on how the care plan is shared with ACO, PCP, and CPs? Mail fax seems not to be very effective. So we didn't really talk so much about how you all are sharing care plans with one another. Someone want to take this one?
So I'll chime in. The community partners send the care plans to our liaison, our community partner relationship manager, who then will help
by email. Yes.
By email.
Right, that's the piece that was missing.
there's other technology in the background too. We're doing it for email. And then she will help facilitate and put the cover sheet on, put the information in there, and then forward it to the primary care for signature, now via DocuSign. And so then it can come back and they can read it. And then it ends up in the patient chart, in their clinical chart, as a document that can be referred to in the future as well.
So I would just like to add to that too. So in our model, we have so many different practice sites and PCP practice sites. So it can be very difficult for our community partners since they're working with all of them. So another thing that we put into place is having a point of contact at each practice site that is prepped and understanding that they are going to be receiving all of these care plans. And that has been, we've seen a best practice because it's only one person at each site that they are working with and that that they can communicate with, and it kind of goes really smoothly in that respect.
Great, thank you. So we have another question. This might be for you, Gary, might be for others. Given payment to CPs is tied to care plan sign-off, and that significant investment in outreach is often needed to engage the most complex clients, can you speak to how the state covered the costs associated with outreach?
Yeah, definitely. So as I mentioned, after a certain period of time, CP payment is tied to member engagement or signing of the care plan. But prior to the signing of that care plan, we actually do cover or do make payments for up to 5 months for outreach and engagement activities. After that 5-month sort of cutoff, if only outreach and engagement activities were provided and the care plan hadn't been signed yet, we would not be providing additional CP payment. So really, there was actually some changes to this particular policy. When we first launched the program, we only had 3 months available for that outreach and engagement sort of period. And we quickly realized that that was not enough. And so we worked with CMS to expand that time frame to the 5 months in steady state. And in fact, when we first launched the program, we actually launched at scale. And so there was a very large bolus of members who needed to benefit from the shared care planning experience. And so because there was that large bolus initially, we actually were able to extend that outreach and engagement sort of period to even beyond the 5 months. But then now that the program has reached steady state, it is 5 months from now until the end of the program.
Great, thank you. I'm gonna take another question here. Maybe this is for you, Leah, but I guess it could be for others. Do you have recommendations in engaging hospital partners in transition of care work? We are a primary care that utilizes collective medical on the West Coast in Seattle and making headway, or maybe trying to make headway with our hospitals.
Yeah, so that's a great question. I think, you know, when I think about the work that we've done from a care transitions perspective, a lot of it has been around education. And so our team has really been able to provide education to hospitals and practice sites and other care partners specific to the role of the CP program and being able to showcase the benefits of larger team coordination. So we are able to use larger platforms that Christine talked about, patient paying collective medical, where we're able to put statements in there. But a lot of it has been not just outreach with members, but also with sites. So we've, you know, developed the ability for bi-directional information sharing, and really, again, putting ourselves out there and taking the lead on a lot of this member care to show the value of the CP program in a streamlined way that is proven really beneficial to building those relationships and maintaining them as well.
Great, thank you. Anyone else have thoughts here, or I can move to a different question? I'll move on. So here's a question. Someone asks, how does MassHealth define high medical / behavioral health needs? What does that collaborative care model look like, particularly when community resources that can provide needed care are limited? Is there a financial incentive involved?
Yeah, I can take a first pass at this one, but would definitely look to others who are closer to answer. So for the BH community partners, eligibility for the program is tied to certain diagnoses, and you know, these are, you know, serious mental illnesses or substance use disorder as an example, and obviously there are specific diagnoses within that, and then in terms, the list of those diagnoses are included on public documentation that you can find on the mass.gov website. So I guess the next part of this question is, how do you, what does the care model look like if the community resources that are providing the care are limited? That is a very good question. And as we all know, especially, well, in all workforce areas, but in particular in the behavioral health workforce domain, it is an issue, right? And I think one of the, and this is something that we have tried to address, not necessarily through the AC or the CP program, but as part of that third bucket of district funding. If you recall, we have made investments at the statewide level for workforce capacity and workforce infrastructure. So one of the ways that we've tried to do this is to offer student loan repayment for providers or clinicians who commit to serving MassHealth members in a community-based setting for 4 years. We've tried to provide sort of like recruitment packages to community mental health centers so that they can attract staff with that kind of incentive payment. But this is definitely a pipeline issue and a MassHealth payment issue and many kinds of issues as well. So it is a real thing. I think one of the benefits, or one of the strengths of the BHCP program, though, is that these are folks who understand, the landscape. Christine was talking about how the BHCPs do things that a primary care provider wouldn't be able to do, or an ACO wouldn't be able to do. And so we want to leverage that existing expertise that is in the community. And then the final part of this, is there a financial incentive involved? The CPs do have a quality measure slate, as I mentioned before, and there is financial, there are finances tied to that. And so depending on their quality performance, they would receive fewer or lesser incentive dollars.
Great, thank you. It's sad to do this, but we are really actually at time. Such a wonderful conversation. I want to thank all of you for joining today and for the work that you did preparing for this. I also just want to take a moment and thank the team that ran this learning collaborative, specifically by name, Vanessa Fenice, Anna Benyo, Jason Turi, Audrey Hendricks. Couldn't have done any of this without all of them. I want to say thank you to MassHealth. Such wonderful work, such wonderful support you provided. It was such a pleasure to work hand in hand with you. And finally, I want to thank the ACO, the PCP, the CP staff who participated in this work and who really worked tirelessly during a global pandemic and who have made such tremendous strides to provide high quality care for the people that they care for. So thank you so much. Have a wonderful day and be well and take care. Thank you.